Thank you all for coming here this morning, for giving up your special and sacred time for a discussion about some of the lessons we've learned in the wake of the passing of legislation in Victoria for what's called, within the legislation, voluntary assisted dying, which in certain circumstances will allow a patient to request of a doctor access to a lethal drug that they can take at a time of their own choosing to end their lives. And in other rarer circumstances would also allow a doctor to do what we call in technical terms euthanasia of a patient who couldn't consume a lethal drug themselves. The brief for this morning is to begin a conversation with you as people who are experts in working with people and caring for people as they reach the end of their lives in those most precious, vulnerable times, about what this looks like now on the other side of the legislation being passed. Because in Victoria, one of the experiences that we had was that we just had a lot of uncertainty beforehand. We did a lot of advocacy work and a lot of public engagement and so on, similar to what you're doing in WA. But now we have, in some sense, the benefit of the view from the day after, where everything's changed now, and on the 19th of June 2019, when this legislation gets enacted, our services now have to operate in an environment where something which was illegal before now becomes legal, and that raises a whole host of different questions for our systems, but more importantly for the people who are working on the clinical coalface, and it raises a whole host of difficult issues for us to find our way around. So that's kind of the parameters for today. I'm going to build on several assumptions right at the beginning. I'm going to name them at the beginning and then walk us through the legislation. I'm only going to yatter away for about 30 minutes or so, but then we've got a good solid kind of hour, 45 minutes to an hour for conversation and questions and stuff like that. So we had a couple of sessions yesterday where we went into more depth on ethical issues surrounding this, the nature of the debate and so on, but that's not really the purpose of today. Today is kind of looking at what I said before, so the day after, what's this going to look like on the ground. I should mention too that I've been appointed as chair of Catholic Health Australia's task force, which is designed to respond to this. Alison is actually a member of that task force as well. And we have a number of people, both clinical and non-clinical, who are helping us to think through all this to try and get everybody on the same page, which I'm going to speak a little bit about later on too. So this is our brief outline today. I'm going to begin with some assumptions, as I said. I'll walk you through the legislation itself. Interestingly, so yesterday when we did the public lecture, beforehand I was Googling online about was there a better way of explaining the legislation, and I went to Go Gently, Andrew Denton's website, and I saw that they had a YouTube video explaining the legislation. I thought, that's great, maybe this will do it in a much quicker way than I can. But it was 17 and a half minutes long, which gives you an indication of the complexity involved in the legislation itself. It's no easy thing, even though it's often presented as such. So we'll walk through that. I'm going to talk a little bit about Canadian experience. We've learnt a lot from similar systems to ours, as in St. Vincent's and other Catholic health providers from Canada, who have had a similar legislation, although it has some important differences, for about 24 months now. And what they've encountered and some of the risks that have emerged for them as well. I'm going to talk a little bit about what we're doing now in Victoria, and then just finish with one of the major lessons from the lead up and ongoing about the place of palliative care in all of this, and what our Victorian palliative care physicians and leaders and other clinicians are now seeing as their role going forward. Because it's been a bruising experience. The whole debate has been a bruising experience for them. So let me just name my assumptions first of all, and you can tell me whether these are fair assumptions or not. Assumption number one is that everyone in this room, regardless of what happens on the back of the current discussions in Western Australia, wishes to continue being excellent in the model of care that you've given your lives to. Does that sound a fair assumption? So that's assumption number one. Assumption number two is somewhat, maybe a little bit more controversial, but maybe not. But I'm just going to assume this for the duration of our time together this morning, and we can discuss this more in the question and answer time if you like. But I'm just going to assume that as people, I know not all of you are working in Catholic facilities, but we are committed to the provisions and the ethical vision provided in the Code of Ethical Standard, which effectively says we'll continue to commit to excellent care, but in that commitment to excellent care, there are certain things that we won't do, which includes what technically in ethical terms are called physician-assisted suicide and euthanasia. So I'm just going to assume that now, but we can have a discussion and debate about that later on if we need to. So you're ready to see the legislation. This is the earliest I've ever shown it, which is quite a risk when you see the slide. This slide, the next slide, was put together by a dear colleague of mine at St. Vincent's who's in charge of medical administration for our group. And it was his attempt as a process thinker to map out the Act on one page so that we could see how our services will intersect with it. The reason we did all of this work is we understand that now that this has passed, this is going to confront our services in one way or another. People are going to request this within our services, and it's our responsibility to understand how the legislation functions so that we can respond to it adequately. So that's what it looks like on an A3 sheet of paper. So far from the kind of benign, simple one-to-one doctor relationship where this all gets resolved very quickly and easily. This is the process that has been mapped out for somebody to request access to the lethal drug. I'm going to step you through it kind of one by one. I would recommend as I do so that all of you think about your position and who you are as caregivers especially, and how this might intersect with your lives and your profession as well. What position this might place you in if similar legislation comes through here. It's largely premised on the Oregon model, which the Victorian government held up as the safest in the world. And what I'll present to you are in effect direct quotes from the Act. So if you're interested in following this up further, I actually recommend reading the Act. It's 170 pages or so, but it doesn't take you long to read because it's that kind of simplified legal speak. So, step one, a patient needs to make a verbal request to a doctor. That doctor can be any doctor. Lesson number one in Victoria, everybody, almost everybody in the lead up to the legislation thought this would be a problem for palliative care to deal with. It started to really, the penny really started to drop. I can actually identify the moment in St. Vincent's. We ran a grand round down at our Melbourne Public Hospital. As soon as everybody who came into that room, many doctors from different professions came into that room and recognised that actually this could be requested from me, all of a sudden the ambience of the conversation changed. It wasn't somebody else's problem anymore. So a patient can request of any doctor access to this legislation. That doctor has to, within 72 hours, respond to that patient's request, either by accepting it, so I will become what's called your consultant doctor, your consultant assessor, refusing it on one of three grounds. One of those grounds is conscientious objection, so I personally don't agree with this legislation, so I'm not going to continue this journey with you. And then it stops there. There's nothing else that that doctor has to do. Unavailability, I'm going away, I won't be able to go through this process with you, or I haven't done the training, and we'll talk a little bit about the training next. The person themselves, so the first thing that this doctor has to do, and it might happen in one consultation, it might happen across many consultations, is go through a process with the patient of checking that they meet the eligibility criteria. And I'm sure you've all seen the eligibility criteria, things like over 18 years of age, has been a resident in Victoria for over 12 months. So how do you check a residency over 12 months as a doctor? Do you normally have to do it? I don't know, but that's the kind of thing that a doctor would have to do in this case. Check for competency, non-coercion, all of those kind of things. And once that doctor is satisfied that the patient is acting voluntarily, they can then continue the process. There are certain criteria that this doctor has to meet. They have to be a fellow of a specialist medical college for over 5 years, or a vocationally registered general practitioner for over 5 years. How many people does that capture in the room? Most. One of the doctors, so there are two doctors involved in this process, at least one of them has to have an expertise in the disease which will eventually, we believe, take the life of the person. Other important criteria is to the best of their knowledge, so these two doctors, they have to establish that the person is likely to die within 12 months or if in certain cases such as motor neuron disease, that's reduced to 6 months. So prognostication is a huge element of this, and within the Act there are provisions for the doctors to seek out expert opinions from others who have been involved in the patient's care to try and understand where they're actually at. So that's another area which might intersect with people who are not actually part of legislation. Completed approved assessment training, we're not sure. There's a lot of uncertainties at the moment about what exactly all of these things are going to look like. The indications we've been given both from the documents from the Ministerial Advisory Panel and also more recent discussions with the task force that's been set up to implement this is that that's going to be some sort of online training for doctors to undertake, that then they'll be certified to be part of this process. The doctor isn't allowed, in fact nobody is allowed to initiate this discussion in substance with the patient or anything to do with this in substance with the patient, which has some other implications that we'll get to later. So in other words, if a patient comes to you as a doctor and is talking about your conditions, you can't say, have you thought about this as an option in substance? I don't know how you police that, but that's provision under the Act. So eventually, Dr. 1 signs Form 1, which says, I'm satisfied that so-and-so is acting voluntarily without coercion, and their request is enduring. Oh, here's some of the eligibility criteria. Disease has to be incurable, advanced, progressive, or cause death, causing suffering to the person that cannot be relieved in a manner that the person considers tolerable. So it's not just about physical pain, suffering in general. This also means that the doctor might be new to the patient, so not necessarily somebody who the patient has an ongoing therapeutic relationship with. The doctor is required to provide the patient with options. The substantive language in the Act is something to the effect of, in the context of palliative care, that the doctor has to explain to the patient what palliative care is and what its likely outcomes are. The doctor is to explain to the patient what other treatment options might be available and what their likely outcomes are. There's no requirement for referral to specialists, unless in certain cases the doctor determines that the person might need a psychiatric assessment. Form 1, whoever's good at counting, keep counting the number of forms. And you can actually access all of these forms by just downloading the Act from the Victorian Government website. Dr. 2 effectively mirrors the same process but is independent of Dr. 1. So the patient gets referred to a second independent doctor. They go through exactly the same process again, have to sign a similar document which becomes Form 2. I said 72 hours before, that was wrong, sorry. When a patient accesses, it has to be within 7 days. So that becomes Form 2.
How does he get the second doctor?
In the Act it says something about referring on to second doctor, yes. Yeah, that's right. Yeah, although it's still a provision for that the person can seek out the second doctor as well. Once these two forms have been done, the patient signs a written declaration. So first request verbal, second a written declaration articulating that they understand the process, they've been given the options and so on, and they want to continue along this journey. Now just to pause it a second here, one of the things that we're grappling with in the context of our task force work at the moment is acknowledging a feature of this kind of process that a patient at this point in time hasn't made up their mind necessarily. Maybe they have, but it's likely that they're exploring an option that's now legally available to them and they haven't yet made a resolution to undertake it. Now think about what that means in the context of our services, which won't be offering this or facilitating it, and yet still want to be an enduring carer for the patient. So you can imagine the different schools of thought that are out there about this. So that's Form 3. The patient appoints a contact person. This person can be anybody really. It's somebody who the patient kind of trusts, and this person has a small but significant role. And that is that when the patient has consumed the lethal drug, if they go through the process, this person is to return the packaging or any leftovers, or if the patient dies before consuming the lethal drug, this person has to take it back to the pharmacy. So you all know your schedules of drugs. This means that somebody, and with no special qualification, will be floating around with a Schedule 8 drug. It will be in a locked box, and we'll go into that shortly as well. So that's Form 4. patient makes a final verbal request to their doctor. We've been through this process. And then Dr. 1, the consulting medical practitioner, effectively becomes a gatekeeper, making sure that everything is in place and that they can proceed with the process. So they get an application form. After doing all of that, they say to the patient, there's no obligation for you to continue through this process now that we've got to this stage, and that's a consistent feature of legislation. It has to be 10 days at a minimum between first request and second request, although it can go over a much, much longer period of time. Then everything goes to the DHHS, so Department of Health in Victoria, who then issue permits. And one of the things we were saying yesterday in a number of the sessions is it's interesting to observe some of the unforeseen consequences of implementing a legislation like this. So the Secretary of the DHHS has to, under the Act, sign off or delegate authority to sign off on every single request for this, which effectively means that it will become somebody's job in Victoria after June 2019 to sign off on every request that comes through. It's an administrative and bureaucratic requirement, and it's a protective measure, but it also, when I read that, I started thinking about, well, what's that person's job description like now? What does that feel like for them to have to read through this stuff? And depending on regularity, if it's 1 a week, if it's 2 a week, 3 a week, what does that do to that person to be signing off on this? It's kind of things that we haven't thought about yet as a society, I don't think, that this will have impact on. They inform this review board that has been set up, and here's where the two different permits can be given. So one is a self-administration permit, which means that the patient can go to a pharmacist, get the lethal drug in the lockbox and take it at a time of their own choosing. The other is the practitioner administration permit, which would, under certain circumstances, allow consulting medical practitioner to administer a lethal substance to the patient. So in technical terms, what we'd call euthanasia. So this is something that we tried to observe in discussions leading up to the legislation. This actually provides for both physician-assisted suicide and euthanasia, whilst it was crafted as physician-assisted suicide alone. Okay, so the permit comes back to the doctor. The patient gets their permit. The doctor has to instruct the patient on how to use the drug. So how to self-administer. They have to reiterate that it has to be stored in a lockbox, that they're under no obligation to administer the drug, and that they must return everything that's not used. A pharmacist then has to dispense, so this is going to create another question of conscience for pharmacists, whether they themselves want to, and we don't know what the drug is yet, so there's a lot of detail we don't have yet, but whether they want to compound the drug or store the drug and be a part of it as well. We're not sure whether there's going to be a register of practitioners and pharmacists that people can access, because one can imagine an awkward situation in which someone does want to make use of this legislation but can't find people who are going to facilitate for them. All of that stuff is just about lockboxes, securing the drug and so on. As far as I can read the Act, the patient has to see the pharmacist in person. So I don't know how that will function either. Does that mean travelling from an acute care setting to a pharmacist? Are pharmacists able to visit the patient and so on and so forth? So that's significant too. If the patient needs practitioner administration, then there needs to be an administration permit, and Dr. 1 is involved with that. Under the Act, there's no supervision required for the person when they choose to take the lethal drug. They do that when they like, at the time of their own choosing. There's also nothing about where they take the lethal drug. So there's no requirement that it needs to be done on private property or in a care setting, or whether or not it can be done in public. So it's an unanswered question, and maybe there'll be guidelines afterwards. I understand that in Seattle or Oregon, when they dispense the lethal drug, and Oregon is the legislation that this has largely been premised on, patients need to sign a thing to say that I won't do this in a public space, but it's not legally binding. Doctor or family may be present. They have certain protections around them if they're present. So that's about practitioner administration. We're up to Form 8. Once the patient has died, if the consuming of the lethal drug has been the cause of death, they're issued with a death certificate. That death certificate lists two causes of death. One is voluntary assisted dying, and one is the underlying disease that caused it. One of the recommendations that went to the government before the legislation was that the death certificate should not say that voluntary assisted dying was a cause, but the underlying disease was the cause of the person's death. And something that quite a few submissions said was, if you're going to legalise this, you should actually be confident enough to name it on a legal document. If we're hiding things like that, it says something about where we think this actually stands. Now, and the legislation itself has actually responded to that critique. It's not a reportable death, but it still has to be reported to the coroner because they'll be keeping track of how the legislation is being implemented and used. And where are we up to now? Anything unused, the contact person returns the drug to the pharmacist. That's Form 7. The pharmacist acknowledges receipt of that. There's a review board that's being set up to make sure that the legislation is enacted according to its provisions, to make sure all the safeguards are being used and so on. They've got to provide reports at 6 months, annually, and 5 years. And VCAT, which I always forget what the acronym means. Oh, there it is, Victoria Civil and Administration Tribunal, we can review decisions, and the Act notes that anybody with, I think it's like a substantial interest in the care of the patient, who could be a medical practitioner, could be a family member and so on, those people are able to appeal to VCAT if they think that this person is going through this process, has been approved and is actually ineligible for some reason. So perhaps they know of coercion behind the scenes or something like that that hasn't presented itself. So VCAT in a sense has a vetoing right. So that's it. That's the process. It's exhausting, right? But just a few other things to say, and then we might pause and have some time for a little bit of discussion and stuff. There is, in the Act, no possibility for organisations to conscientiously object to the legislation. So individual doctors are protected, but there's no provision that an organisation like St John of God, St Vincent's, Mercy, or whoever, to say that we're not going to be facilitating this. We don't know where that leaves us. In the introduction of the legislation to Parliament in the third reading, the Minister and a number of others made guarantees that no organisation will be expected to do that, but we really, apparently, and I don't understand the legal stuff very well, but the third reading doesn't have any kind of legal weight, as it were. It helps to interpret, but it doesn't have as much weight as the second reading does. So that's significant for us. That's something that we have to be thinking about. We don't know what the constitution of the lethal drug is, so we don't know if it's compounded or a specific drug. And we also don't know what the storage requirements are, other than that it has to be in a locked box. We also don't know what the storage requirements are if somebody comes into a care facility already in possession with the drug. So we assume that this will happen, that somebody will be admitted to one of our hospitals or aged care facility who's been through the process. The only kind of informal kind of guidance we've been given on this, and nothing's been written down yet, but this has been in the context of kind of brainstorming task force meetings and so on, is that if they come into a care facility, we won't be able to ask about it. We won't be able to ask if you have the drug on you. And if we know that they have it, we won't be able to store it as we would store other medication. So that's still up in the air. And maybe in a month we'll be able to give a more substantial answer to that. We don't have any information yet, and the Act is kind of silent on cases in which the drug is ineffective. It does note that these cases might happen, but it doesn't give a response to what happens next, as it were. We don't know what the training looks like, as I said before, other than that every indication has been it's going to be some sort of online training module. And we also don't know, in other jurisdictions like in Canada, in Alberta especially, the government has set up what they call a navigation service, which is a body of the government who people can contact, make an appointment with, and discuss the process independently of other healthcare providers. we don't know if the Victorian government is thinking about something like that as well. Because, as I say earlier, it's very uncertain about who's going to sign up to do this, both doctors and pharmacists. And then the second uncertainty is if somebody's pursuing this, how they access those people. And that brings into all the kind of questions around cooperation and so on of people who don't want to be involved in this. In some sense, what we're trying to do in our services now is say, we still believe in our model of care and we're going to endure in it. We're going to keep being impelled to provide excellent care, business as usual. But we're also taking this seriously enough to be responsible enough to think about what are the issues that are going to arise and how can we navigate those in a sensible way that's congruent with our ethical framework. So here are some of the issues that we anticipate arising. I won't go into any detail with them because you can imagine the scenarios. So discussions is one, when somebody brings this up, and when somebody's seeking after this, how do our clinicians engage with that? Requests, direct requests to our clinicians. Transfers or gate passes, if somebody wants to leave our services for a particular point in time to go and visit a non-objecting doctor, do we actively facilitate that? Are we obliged to actively facilitate that? And if so, then all those questions about cooperation come up. The real kind of neuralgic point around this at the moment is if a person is so fragile that giving them a gate pass is impossible or transfer in and out is overly burdensome to them or the system, would we ever allow people on site, non-objectors on site, to have the consults on site? Assessments, possession of the lethal drug, as we've spoken about before, patient has taken the drug but it hasn't worked. So those are the things that we are grappling with at the moment.
Can I just ask you that idea about patient taking the drug and it hasn't worked? Do we have any stats from the US, for example, about how many patients take the lethal drug and do not die? Yeah,
there are. It's what I'd call a substantial minority. So it's certainly not a majority. It works in most cases, but it's not an...
Are we talking about 1% or 5%?
I can't remember the percentage off the top of my head, but it's more than a handful, if that makes sense. Yeah, and for some it works, but it takes much longer than what's on the box. Like it'll take a week rather than a couple of hours.
I think the Victorians are trying to invent this drug, aren't they? And they're trying to produce a drug that's going to...
I actually don't know, but yeah, we have heard this compounding kind of pulling...
We don't even know how it's going to work.
Yeah, and how do you test it? So, as I mentioned before, we've done a lot of work with colleagues in Canada. The Canadian legislation is different to Victorian legislation. The Canadian legislation is primarily for euthanasia, so they require a doctor on site. I spent a lot of time with our Canadian colleagues over Skype and things like that to try and understand their response. And it deeply impressed me, their response actually, because they said, well, Dan, you're in a different situation now. It's the day after. You've got your deadline of June 2019. Here are the things that we'd recommend that you do in Catholic services specifically. Number one is get everybody around the same table. And their comment about this was, we can't afford to have 100 different responses to the legislation because you'll end up with some that are just bananas and don't work at all. You'll end up with some that are very well thought through. But the fracturing between your services will itself say to everybody, your patients, your staff, the public, that you haven't done the due diligence to think through this properly. You haven't been responsible enough to care, especially for your staff, and prepare your staff for this, but also for the vulnerable patients that you're caring and residents that you're caring for. So they said, get everybody around a table, which is the task force that Alice and I are a member of, which we're attempting to do, is get all the players around the table so that we can come up with commonly agreed ways forward. They said it's not enough just to have the systems around the table. Having church leaders around the table is also very important. Because it's one thing to say, no, we're not going to facilitate this, but the complexities in those scenarios I just described don't go away by saying that. We still have to deal with those, and that's going to take us into tricky territory. And it's important, they were saying, that you know that everybody's got each other's back. Everybody knows that we're on the same page with this, and everybody's agreed to principles that we can work through. They also said, get the government around the table too. Keep up your good relationship. And it became a tense relationship during the debate. But keep up your good relationship with them. Make sure you acknowledge the good things that they're doing and support those good things, but also keep them posted on where you're at in terms of responding to this, so that they know that you're doing this in a responsible manner. You're not like the child who's thrown the toys out of the cot and just standing there with your arms crossed. But you take healthcare seriously, and you want to ensure that you can contribute in an enduring manner to the common good in this country, even when something you disagree with has been legislated for. So that was their big advice to us. They also said, it's going to be tough. There are going to be things that come up, and there are going to be people watching you, waiting for you to stuff up, as there have been in Canada. So these are two media stories from the Globe and Mail in Canada. They were published 2 days after each other. And I'll just tell you a little bit about each of the stories. You can look these up if you're interested. But think about these in the context of your care provision, and you can just kind of imagine similar kinds of things happening. So first story was about a Jewish care home in which a man wanted to access medical assistance in dying but couldn't because it was an objecting facility. And effectively, the way the story goes, it reads kind of like a dramatic 3-pager in a novel somewhere. The family smuggled in a doctor into the care services facility, locked the door, had to keep their eye on the door while the doctor administered the lethal dose to their dad. And it was kind of told as this, we hoped for a peaceful death for Dad, but it became this awful moment of, having to watch the door and worrying that someone will burst in at any moment. So here you have a facility which has conscientiously objected, obviously explained that to their patients and their residents. Residents still wants to access it, and this is the kind of outcome of it. 2 days later, the story on the right was published. It referred to an incident the year before in which St Paul's Hospital in Vancouver was transferring a patient out because that patient had resolved to have medical assistance in dying. So they were transferring them to a receiving facility that had agreed to take the patient. That's another significant thing. You can't just transfer someone to nowhere. You've got to have a receiving facility. But St Paul's stuffed up the transfer. So this patient was left in an even more vulnerable state than when they left because the paperwork wasn't done properly. Receiving hospital then didn't have the right medications, didn't have a bed and all this kind of stuff. Within 2 days of each other, and this was the big storm in Canada for these providers right at the beginning of the year, and it was coordinated. It was, activist groups who were watching and waiting for the Catholic services and other objecting providers to stuff up. So that's something else they said. They said don't assume necessarily, we should always assume goodwill of people, but don't assume that you're always going to get things right, number one. We already know that. But people are going to be watching. So be diligent in the lead up. And be honest too. They apologized. St. Paul's wrote a beautiful letter of apology for that. So just probably 3 or 4 minutes more of me speaking, then we can come back and have our discussion the last 15 minutes. This is what we're doing now in Victoria. This is the work. So effectively where we were is this left box here, and that's where kind of the area that you are now. So this is about political engagement, public discussions, internal communications and so on. One thing I would say is that I don't think we did our internal communications well. I talk about St Vincent's. I don't know as much about the other services, what they did. And I think that was a real lost opportunity because people knew we were out there in the public square advocating against the legislation, but they didn't know what positive option we were offering. So they started to see us as the kind of Catholic mob who's against everything as usual, etc., etc., etc. Where I don't think we did a good enough job internally. I think we did it externally quite well, but internally about articulating our model of care and being bold with it. So that's important because that has a gravitas of its own. Even aside from the debate, we should be doing that stuff anyway. But here's what it looks like now. So the bottom layer here is St Vincent's work, and then the top layer is sector-wide work. So we have our CHA response task force, which is trying to do that work of getting everybody around the same table. We also have a group of ethicists who, effectively, this group have said, here are the tricky issues we see. We need good advice on these issues. So that group meets on Monday. And then hopefully we'll come up with some good advice to go back to this group. And then in each service, whatever high-level guidelines this group provides, the services will think about how they apply in those contexts. What we've determined as necessary within St Vincent's is obviously to have good, clear clinical governance. So this is a project that's co-owned by kind of mission, but also more importantly and more substantially owned by our clinical governance and medical administration teams, so that we have good policy and guidelines. International benchmarking is testing this against other similar services overseas. Once we've got some of that stuff, we're going to do a bunch of scenario testing, and this has been one of the big learnings for us so far, is that what sounds good in the abstract, when you place it in the middle of a scenario, changes entirely. And so if you do get to this stage, one of the things we did with our board of directors and our executive leadership teams at different hospitals is actually create scenarios built around the Canadian experience and put them in the scenarios and say, this is what it looks like. What decision would you make right now? Because that changes the way we see the issues at hand, and it takes us out of the kind of esoteric realm of this sounds nice into what's actually going to work on the clinical coalface. And then implementation. So we're anticipating that this ongoing education and then monitoring afterwards, but the education part is going to take the full 6 months at the beginning of next year. So effectively all of this work has to be done by the end of this year. Now, look at how resource intensive that is. And this is a provider that's not going to facilitate it. Apparently the other providers are only just starting to think about what does this look like in our services, the public provider. Are we going to take part in it? Are we going to have a specialised service and so on? It's fine for a big group like St Vincent's to do all of this work too. We've got resources to boot and we can throw them at this kind of stuff. But smaller providers are in a much more difficult situation, which is another reason for that task force up above. And the final thing to say, and then we'll stop and we can have some discussion, is this is a big learning for me throughout this whole process and even now, is like our services and the professions that you've dedicated your lives to have a thoroughly beautiful model of care which exists in a context in which people don't want to talk about it. Because death is such a taboo in the Western and Australian culture, they come to you too late and we have our rich conversations with people too late. And yet when we have those conversations well, and you know this from your own experience, people become thoroughly convinced that this is the excellent way to care for people at the end of life. I said to the group last night, the big question of ethics is, what is the most excellent way to do A? Well, what is the most excellent way to care for people at the end of life? I think we have really robust, beautiful, creative and courageous answers to that. And now in Victoria is our time to articulate and witness to those answers more. And I use that word witness in its kind of full breadth of meaning as manifested in the way we live and move and have our being. It's a slightly religious term, I know, but it's about kind of embodying this. Because ultimately that's going to be the answer to all of the tricky ethical questions we're dealing with. We don't need to run down a rabbit hole and worry about them. If we just continue to witness to our model of care, we actually show that this is a more humane, a more dignified way of operating. I think we've been shy with that. And I still think, the model of care, as you know, can still develop. We don't have answers to everything. We're not magicians, as you were saying before, Alison. And yet we can do so much. And as in any field of human endeavour, we will get better over time. But we also need to be engaged in kind of making that known to people, to communicating to that people. And so that's what I see as actually the bigger work here. Legislation's complex, but actually our more important work is to do business as usual and just get more and more excellent at that. So that's all I had for this morning. Thank you very much for coming and listening and chatting. And we still have 15 minutes left, so let's take some time for discussion and everything.